Welcome to Marrow Masters Season 15, sponsored by Kite, a Gilead company, and Bristol Myers Squibb. The National Bone Marrow Transplant Link, established in 1992, strives to help patients, caregivers, and families cope with the psychosocial challenges of bone marrow and stem cell transplant, from diagnosis through survivorship. Season 15 of our show focuses on CAR T cellular therapy. This innovative and life-saving treatment is gaining momentum and has become a first-line course of treatment in recent years. We will dig in, learning more from clinicians, survivors, a caregiver, a nurse, and a psychologist. This season will offer education, insight, hope, and so much more. Here's your host, Executive Director of the NBMT Link, Peggy Burkhardt.
Hi, everyone. Today we welcome Dr. Hemant Murthy, Professor of Medicine, Division of Hematology Oncology at Mayo Clinic in Florida, who will talk to us today about CAR T clinical trials. We're going to cover the who, what, when, and why of it all. So let's dig right in. Welcome, Dr. Murthy.
Thank you, Peggy. It's great to be here, and thank you for having me.
Thank you for being here. Dr. Murthy, there is so much progress, hope, and excitement right now centered around clinical trials and CAR T. Let's start at the beginning, though. Why are clinical trials in general so important in hematology?
So something we may need to do to really understand how critical clinical trials are is to kind of take stock in where we are right now, even in hematology. And I think when we look at the current landscape of how we treat people, some things maybe we take for granted. A patient with newly diagnosed chronic myeloid leukemia has the option of going on an oral pill like imatinib or dasatinib. A patient with newly diagnosed multiple myeloma may get a regimen that contains drugs such as bortezomib and lenalidomide. But these drugs that have really changed how we manage these diseases have all come from clinical trials. We now treat acute myeloid leukemia in older adults completely different with combinations such as venetoclax and azacitidine. And even more recently, we use something called post-transplant cyclophosphamide for allogeneic stem cell transplantation. All of these advances, all of these survival improvements that we have in hematology all really come from the backbone of clinical trials. So I think sometimes we may take it for granted, but then when we look back, we really have to realize just how important they are to our current state and subsequently our future state.
Oh, that's such a great point. Thank you for sharing that with us. So we're going to get right to it on CAR T. So this has been a transforming therapy, and it's really changed the way that you're treating diseases today. Talk to us about that.
I've been fortunate to have been seeing CAR T treatment since even before its approval, back when it was still in clinical trial. And, as a story itself within clinical trials, CAR T really is a true success story from start to finish. There were patients whose survival was dismal. The lymphoma patients that we knew based on the SCHOLAR-1 trial had expected life expectancy of months. Same with pentarefractory multiple myeloma. Refractory acute lymphoblastic leukemia. These are patients who, in all reality, were heading to hospice.
Wow.
And these therapies really transformed how we treat patients. I mean, examples really are the fact that now we consider these treatments earlier rather than as a last line of defense. Even trials that are looking at this in frontline therapies, we're looking at how this impacts the way other treatments are utilized, such as bone marrow transplants. In some instances, transplants like allogeneic transplants for lymphoma have dropped because of the success of CAR T. And it's continuing to change how we treat as we develop more treatments that are approved with CAR T. We don't have to wait till the end, but can we treat these people earlier on and get the same kind of benefits from it? So I think it has dramatically changed. It has really opened up a whole new avenue of treatment. And I still think there's a lot of change still yet to come with this.
It's so interesting. I remember in the beginning, I would hear that it was the Hail Mary or it was the last ditch effort. And it is so exciting to hear you say this, knowing that people don't have to think, like you said, that they're going to be in hospice, that they could possibly die. CAR-T is making just a monumental difference, it seems.
If we're going to stay with a football term, sometimes, yes, a Hail Mary works. But the more times a Hail Mary works, we start wanting to use it at second down and first down.
I like that. Very true. Let's jump in about the approval process and the approvals of clinical trials.
So based on seminal papers, registrational studies, we do have a number of new indications now for CAR-T. We have 3 CAR-T products, the axicabtagene ciloleucel, tisagenlecel, and the lysocabtagene maraleucel, which are approved for diffuse large B-cell and non-Hodgkin lymphoma. We also have brexacabtagene, as well as liso-cel approved for mantle cell lymphoma. You have 2 products, Abecma and cilta-cel, which are approved for multiple myeloma. 3 now for follicular lymphoma, 1 for pediatric ALL, and 2 for adult ALL. So these all have had trials where they have shown such impressive results that they were approved. Then not only have they been approved, but then to get them approved for earlier line of treatment, particularly the axi-cel and the liso-cel, had positive phase 3 results when they were compared with salvage chemotherapy and transplant. So now this is where people are considering, well, I have a relapsed leukemia. Before it was always one path, chemo, transplant.
Okay.
And even if you gave them chemotherapy, if they did not respond, they couldn't go to transplant.
Mm-hmm.
So you really have now a true other option, which in a randomized trial was shown to be superior than the standard of care. It's good to have options. It's good now that we can potentially change the landscape of how we treat people.
This is terrific. Oh, it's going to give so many people so much hope. So how can people find out more about the reputable clinical trials? Where should they go? What should they do?
This is a great question because I think somewhere along the lines, we as investigators, we open these trials because we want to get these trials to patients. And patients constantly will ask, how do I learn about these trials? So sometimes it's almost like, well, how do we marry the two together? So from the patient standpoint, I would say the first thing is talk to your oncologist. Ask them about clinical trials. Are there trials available? And I think our job is also to dispel any myths or concerns about clinical trials because, again, all these advances in our field come from clinical trial.
Mm-hmm.
And you should learn as much about the trial. So when you want to know about a trial, we should know what phase the trial is. A phase 1 trial is very early, sometimes first in human. The goal is to assess how safe a therapy is.
Okay.
Phase 2 trials are assessing how effective an intervention is. And a phase 3 often is a randomized trial where you're comparing to see whether the treatment is better than the existing standard of care, sometimes even a placebo-controlled trial. So ask about what kind of trial it is. If risks are known, ask about that. Sometimes people can check on the internet and hospital websites like our website, many of the cancer center websites will have a list of clinical trials based on the disease. And all these trials have to be registered on clinicaltrials.gov. When you go to that site, they will have contact information. Typically, they'll also have the names of the principal investigator. And this is oftentimes how we also, as physicians, I want to get people on trials that I have here. But in the end, I want my patient to get the best available treatment. And if that means I need to send them somewhere else to someone who has a trial, then we'll do that. And we're a small community and we know each other. Many times we're doing the same trial at multiple institutions, whether it's through the National Cancer Institute or we're doing it through industry sponsors. So we have sent patients to other centers. Other centers have sent patients here. In the end, all of us want is your health and remission. And we don't care by hook or by crook how we can do it.
Oh, that is just so great to hear. Because I think people do wonder about that. I'm near this one center, but I think there's a trial somewhere else. I don't want them to give me a hard time. I want someone advocating for me, which is a big part of our mission. So it makes me very happy to hear that.
It's good you raised that, because sometimes knowing whether someone can come onto a trial is about, and this is another thing someone should ask, is ask about the study visits. Ask about how many times you have to come back, how long you have to remain somewhere, and you have to weigh these things out. Sometimes if your disease is getting to a point where you have to stay, a lot of times the cancer centers will try to find a way to help with lodging, to help with staying nearby. But some trials, especially CAR T and intensive treatment, they require you to stay close for your safety. But those things you should also ask. And when a study is presented, these things should typically be presented to you before any kind of signing of consents.
This is just great information. I didn't know about the study visits, so thank you for filling us in on that. So what's on the horizon? I hear all the time there's all these different disease states that there are trials up and coming. Let's talk about that.
So there's a lot of things that are coming that are already in the research sphere. We actually now have 2 approved cell products for solid tumors. We have tumor infiltrating lymphocyte or TIL therapy for melanoma.
Okay.
Which is really has started to take hold. And now we have a lot of patients that are coming in. They get a sample from their tumor harvested, and then they collect the actual lymphocytes that work against that. And then we go ahead and then basically we manufacture using those cells and infuse them back in. And really we've had some very good success. And this is now a new FDA approved therapy. We just recently, I think more recently, had an approved T-cell therapy for synovial sarcoma approved. So I think there is a lot of excitement now with the advent of cellular therapies in particularly solid tumors. There are clinical trials that are ongoing for different solid tumor malignancies: breast, ovarian, pancreatic, hepatocellular, lung, there's glioblastoma.
Wow.
So there's a lot of things that are now being new indications. But beyond new indication, there's also the cool technology, the things that really, I kind of call it Star Wars because some of them it's just so cool.
Yeah.
There are trials, and typically all of these cellular therapies, all the approved cellular therapies involves collecting your own T cells.
Uh-huh.
That takes time to manufacture. So there are trials looking at rapid manufacturing. There are trials that are looking at using donor T cells and gene editing those T cells to make them safe to administer. There's also taking advantage of different immune cells other than T cells, such as natural killer cells, monocytes, macrophages, and encoding CAR genes on these and seeing if these are impressive as cellular products. There are trials to make the existing CAR T better or safer. After you infuse the CAR T cell, can we make it persist longer? Can we give medication to prevent toxicity? So there is a myriad of trials going on, and it's not just looking at the next malignancy, but also trying to build on what we have and make it safer, faster, more effective, more accessible to people.
Wow. When you were talking about all the other indications, it just made me think, and I'm sure a lot of our listeners could relate, loved ones that we all lost even 5-10 years ago, that maybe it would have been a different outcome had this been available. And it makes me sad, but it makes me hopeful for the future.
I feel like the same way. And I think, sometimes we wish we had what we had before.
Mm-hmm.
And other times we're grateful that the people who come to see us today have what we have now. One example I can honestly tell you is my father-in-law was a pathologist who just retired, and he graduated medical school in 1970.
Oh, wow.
And I had the chance to go into his basement, and actually he had a lot of his old medical school notes. And I started flipping through his notes, and he had things where multiple myeloma had a life expectancy of weeks.
Really?
And chronic myeloid leukemia was practically a death sentence.
Mm-hmm.
And these are the things sometimes, again, we feel bad that we didn't have what we have now, but also makes you marvel at where we are today. It is a relatively short amount of time that we have made dramatic increases in diseases. And I think we may look back the same kind of time period, 30, 40 years from today. We may look back 30, 40 years from now and say, wow, what an amazing transformation it has been since the advent of things like CAR T therapy.
I believe it. I mean, think how far, like you said earlier, the clinical trial drugs. And I just went to a conference on GVHD, and just to see how far, how many drugs there are now. And so it's multiple fields. And thank goodness for clinical trials. Felt it was really important to have you talk about this, because it's really where it all starts, isn't it?
It really is. I think everything that we do, we owe, in oncology, we owe almost everything that we treat people with to clinical trial. Clinical trials have not only developed better treatments, they've developed safer methods of treatment. Think about even that. Even the drugs that we use to prevent nausea, the symptoms, those come from clinical trial also. So a lot of the things, even the things that are behind the scenes, are from clinical trials. I'll give you one example of something where clinical trial, this was one of the first patients I remembered as treating with CAR T as a fellow on one of the original clinical trials. And I still remember this person getting their conditioning chemotherapy and seeing his lymph nodes every single day. I would assess it. The lymph nodes are getting bigger by 1 inch. I could visibly see it. They were bulging and infused the cells. Things got better. And I had graduated by that point. So, I lost track of the patient until maybe about 2-3 years later. I saw a video on the internet, and it was the same patient. And he was talking about how successful the treatment was, how successful CAR T was, and how grateful he was to be on that clinical trial.
Oh, isn't that great?
And that's the amazing thing that can happen with it.
Absolutely. That's so inspiring and gives so much hope. Oh, Dr. Murthy, thank you so much for this today. Is there anything else you'd like to add before we wrap things up?
Feel free to ask questions. Whether it's me or it's anyone. I think the hardest thing is to answer something when someone doesn't ask the question. I think be inquisitive, be probing, ask lots of questions. I'd rather know about the little things and answer the question than potentially miss the big thing because it wasn't asked. We're here to help. And if there are things that we can offer, we absolutely want to offer this. And I think there are so many things that we're doing that really can help. And we're here for all of you.
Well, it's very obvious your compassion and your time today. Really, really appreciate it. Thank you.
Thank you.
This has been the Marrow Masters podcast. If you know someone who would benefit from the information in our show, please share this episode with them. And don't miss future episodes of our show. Follow Marrow Masters for free on Apple Podcasts, Spotify, YouTube, or wherever you're listening right now. And to connect with the National Bone Marrow Transplant Link, visit nbmtlink.org or tap the link in our show notes.